Okay, let's wind up the morning and talk about stress fractures, which leads off nicely from Mike's talk on metabolic bone disease. So we're seeing an increasing incidence of stress fractures throughout our population right now, and it's estimated that in the U.S. about 15 to 20% of all fractures are created by repetitive rather than single episode injury. And that's really the definition of a stress fracture, is that you have multiple episodes of minor trauma, but your body isn't able to heal them. You don't give the body enough time to repair those little bits of micro damage, effectively lowering the failure point of the bone. And so we're seeing these because our patient population's aging, and there's still a great emphasis on physical fitness, and we're seeing a lot of people like Mike's friend, the 62-year-old who's actively involved in sports. Now, these stress fractures are traditionally divided into two types. The fatigue fractures, where the bone is normal and you have repetitive stress, and insufficiency, where there's something wrong with the bone, either in terms of its elastic resistance or repair capacity. In reality, we see a lot of overlap cases. So we have older patients who are very, very active, and we have younger patients who have some type of metabolic bone disease. For example, they may have an eating disorder, which is quite common in the female athlete triad, where we have a hormone imbalance and an eating disorder and decreased bone mineral, all acting together to increase the risk of stress fractures. And vitamin D deficiency is a really hot topic right now in the orthopedic literature. I think the values are not very accurate because the incidence seems to be way too high to me, and they are being adjusted. I just think if anybody can come up with an app that gives you sunlight through an iPhone, you're going to make a fortune. I just want 10%. Okay? All right. So insufficiency fractures can occur in a number of different locations, but the most common places that we see these are going to be involving the vertebral bodies, the pelvis, and the lower extremity. They're not very common in the upper extremity. I had a case just last week of a patient with an acromial insufficiency fracture from using a walker after she had a total hip arthroplasty, but they're relatively unusual. Don't forget the problem with bisphosphonates. This is a very, very important thing to be aware of, that patients who are on long-term bisphosphonates are unable to repair damage, and it's thought that the increase in tensile force in this area that we all experience doesn't get repaired in these patients, and they wind up with bony hypertrophy and cracks that can ultimately go ahead and complete into a fracture. But that's just one of the many, many causes of insufficiency fractures, and we've heard about several of these in the last presentation. Osteoporosis gets the most attention, but it really only explains about 50 to 60% of fracture risk variance. A lot of the bone strength that we have doesn't come just from how dense it is, but by how the architecture is organized, what the quality of collagen is in there, what the patient's tissue quality is overall in terms of their collagen. But architecture is something really important, and there's some very nice work going on here at NYU by Greg Chang, who we heard from this morning, about microarchitecture. So the architecture of bone also, kind of like the way a box works, where having those little struts inside really greatly increases the strength of the material, is something that we need to consider. For example, this is a toothpick tower made from very small toothpicks. It can hold a 2-kilo weight. My husband got an A in my son's grade 9 science project for this. But architecture also matters. And we know that these cross struts can really help you take weight. If you go to your house and look at your chairs and stools, the taller the stool, the more cross struts it's going to have in order to be able to support weight. And that's really how our bone works. We have our primary trabeculae along the main weight-bearing axis. We have cross struts that are perpendicular to that. And it's in the plane of these cross struts that we wind up seeing fracture. So loss of these secondary trabeculae leads to failure of the primary trabeculae. And that's a good thing to remember, that you're always going to be looking perpendicular to those long axis trabeculae. You're not going to confuse these with fracture lines because they're running in the axis.